we'll be moving on to the third session, which will be about pediatric vasculitis and vaccination in rheumatological illness. To chair this session, I would like to invite Dr. B.K. Bhuya Sir, President of IIP Odisha State Branch, Dr. Biswajit Mishra Sir, ex-Vice President, Central IIP, and Dr. Pradeep Kumar De Sir, Senior Consultant, Pediatrics at Assam Ultimate Medicare, onto the stage. Now I would like to invite the first speaker of this session, Dr. Dhrubajyoti Sharma Sir, Associate Professor, Department of Pediatrics, Fakhruddin Ali Ahmed Medical College, Barpeta, Assam, to share his knowledge on how to pick up Kawasaki disease in a child with fever.
Good morning, everyone. Respected chairpersons and my seniors and students friends. As you all know, the 10 years back, the diagnosis of Kawasaki disease was very rare. We got very rare cases. But now we are in a situation, even our general practitioners do not mix Kawasaki disease because there is a very beautiful clinical diagnostic criteria on it. And here the fever is the major criteria, and other 5 to 6 principal features. And when the patient fulfills 4 out of these principal features, then the diagnosis of Kawasaki disease is sure. And these parameters, that means the rashes, edema, periangual peeling, conjunctival injection, strawberry tongue, these all were initially described by Dr. Kawasaki himself 50 years back. And these are still relevant, only there is little modification in the diagnostic criteria. So the topic is clinical clues. So my topic, my discussion I will restrict to clinical parameters only and routine laboratory tests, no whole exam sequencing type of diagnosis. So problem occurs when the child present with fever of unknown origin. Because here, if we do not think of Kawasaki disease, the diagnosis become very difficult. So I always tell our residents, when any children come with fever for 5 days, always think Kawasaki disease is a differential diagnosis. Otherwise, we may miss the diagnosis. So our challenges are correct identification and timely treatment. As we all know, if we do not diagnose the disease on time and initiate treatment, that will lead to very fatal complications, coronary artery aneurysm and early cardiovascular death. So these are the pictures of the clinical features during acute phase of Kawasaki disease. Rash, conjunctival injection means there is no exudate, and cracking of lips. We get this picture in an acutely febrile child, probably there is no differential diagnosis. Then strawberry tongue, cervical lymphadenopathy, which is usually unilateral, can be bilateral also. Then edema of extremity. These are the features, periangual desquamation and this desquamation of the hands that we get in subacute phase. That means fever, that means after 7 days of illness. Then Bu's line we notice during convalescent phase, say after 6 to 8 weeks of illness. The problem is the clinical symptoms and signs evolve over time. So that is why there is a difficulty in early diagnosis, but when we give a careful observation after admission of the child for new signs and symptoms, then it will be not difficult to diagnose. Then patients who present late, that occurs in infants, as that was discussed very beautifully yesterday by Dr. Vijay, and patients, children who present late, say after 5 years of age, those children do not present initially with all the features. So some clinical features may have evaded, parents may forgot about those features. Then rash, extremity swelling, conjunctival injections are very transient events, last for 2 to 4 days, then subside itself, and rashes, that is polymorphous, mostly occurring in the trunk and the proximal extremities. So those areas are under cover of clothes. So parents may not notice. Then there can be misdiagnosis like measles, UTI, urinary tract infection, sometimes PIGN, post-infectious glomerulonephritis because of edema. So that is why careful review of the history is important. Then this is a 7-year male child from Kokrajhar, that is western part of Assam. Child presented with fever of 10 days, 102 to 104. Febrile pallor was there and pulse was there, was tachycardia. Systemic examination findings were unremarkable and child already received septic reaction followed by meropenem outside. So in this such a case, we keep this differential diagnosis as a investigation for pyrexia of unknown origin. So maybe infectious diseases like Epstein-Barr virus infection, dengue, HIV, bacterial like otitis media, always we check the year before we proceed. Then urinary tract infection, enteric fever, deep-seated abscess, tuberculosis, infective endocarditis, even brucellosis. Then rickettsia like scrub typhus, then parasitic infections like malaria, toxoplasmosis, visceral larva migrans and Kala-Azar. Then autoimmune diseases like Kawasaki disease, SLE, vasculitis, hemophagocytic lymphohistiocytosis and autoinflammatory syndromes. Then malignancy like leukemia and lymphoma. So these are the differential diagnoses we keep in mind. In this index child, what we got, there was mild anemia, tachycardia was there, which was polymorphonuclear leukocytosis, thrombocytosis was there, ESR was in 3 digit, 102, CRP was 93, AST, ALT, there was, these were mildly elevated, serum albumin was low, sodium was low, and urine routine examination that revealed 6 to 8 pus cells per high power field. Other investigations like scrub typhus, dengue, malaria, tuberculosis, skin test, chest X-ray, all are negative. Then ultrasound abdomen was normal, and echocardiography that was basically done to rule out vegetation were negative and no coronary artery abnormalities. So where do we get 3-digit ESR in a febrile cell? Tuberculosis, malignancy, Kawasaki disease and certain other connective tissue diseases like SLE, systemic JIA and other vasculitis. In this index child, the previous study revealed microcytic hypertrophic, some sort of nutritional anemia are there in children in our part. So increase in the number of platelets and bone marrow study, ANA, ANCA were planned but not done. So if we go through the pyuria in Kawasaki disease, if this is a Kawasaki disease. So it is described as sterile pyuria that is found in 30 to 80% of patients with Kawasaki disease. This is because of urethritis, cystitis, subclinical or clinical renal involvement and not always sterile because Kawasaki disease can be associated with urinary tract infection. So other differential diagnoses are SLE, nephrotic syndrome and renal tuberculosis. On day 3 of admission, that means on day 13 of admission, the index child developed this typical desquamation. It has progressed because we have not noticed initially. So we can see there is sloughing of the skin in the palm and soles, and we have immediately treated this child with IVIG and there was dramatic response. So this is a very beautiful algorithm to diagnose incomplete form of Kawasaki disease. That means the children who do not present with all 4 principal features, less than that, then we can go through it, and infants with fever up to 7 days without any definitive diagnosis, alternative diagnosis. Then we have to go for the acute phase parameters like CRP and ESR. If those are raised, then we have to go for other 3 of the laboratory features, anemia, thrombocytosis, low albumin, elevated AST like that, and or if there is positive echocardiography, that means echocardiography is showing coronary artery aneurysm involvement. Then we can pick up the case as Kawasaki disease and immediately we can start the treatment. This is a 7-month-old girl from Nagaon, Assam, that is situated in mid part of the Assam. So fever for 2 days, history of convulsion on day 1 of fever, irritability, ear examination was normal, always we check the ears to rule out otitis media in a acutely febrile and irritable child. CT brain was normal, that was performed before referral to our hospital because convulsion was there, can be something inside the brain. Then CSF revealed normal study. So hemogram showed anemia, leukocytosis which was polymorphonuclear, platelet count was initially normal, But when after admission of the child in our hospital, we have repeated after 1 week, that revealed thrombocytosis. ESR was in 2 digit, CRP was raised, urine culture, blood culture, LFT, RFT, all were within normal levels. So fever child presented with fever, irritability. Then we have instituted the treatment with ceftriaxone and other supportive treatment like paracetamol. On day 4 of illness, child developed watery diarrhea. So we have started on ORS and zinc. But on day 8, child developed this typical perianal desquamation. Fever persisted, irritability persisted. These are the 2 things why we have we were not sure what was exactly happening to the child. So initially the desquamation, our residents thought that it is because of perianal excoriation in a case of acute gastroenteritis. But no, you can see that was not raw, dry, and periangular desquamation has extended. We can see the typical peels in the skin. So we have instituted the treatment with 2 gram per kg IVIG, and that responded very well. So we can see the irritability in this index child. How can I play the video? How can I play the video? Okay. You can see this irritable child here during acute phase of KD. This is after treatment with intravenous immune. So child is smiling. We can see the difference. And another thing probably you have noticed or not, I don't know. So when child was irritable, father was not there. But when child became happy, then playing, at that time child came to the picture. The father came to the picture. So this is a 10-year-old child from Dhubri, Assam. That is also western part of the Assam, where newly established Dhubri Medical College is there. So 8 days history of fever, limping with decreased mobility. We got mid-inguinal point tenderness, decreased range of motions. So, and the laboratory investigation revealed polymorphonuclear leukocytosis, thrombocytosis, high ESR, CRP, AST, ALT, albumin, all were normal. So, probably we can take it as a septic arthritis, no differential diagnosis initially. So, we have initiated the treatment with ceftriaxone, amikacin, vancomycin and naproxen for pain, and orthopedician came and immobilized the joint as a part of the treatment. But there was no clinical improvement even after 48 hours. So we did a USG hip joint ultrasound that revealed thickened joint capsule with minimal fluid and suggestive of inflammatory arthritis changes. So it became an inflammatory arthritis. We do not know what is happening to the child. So ultrasound abdomen was done to rule out psoas abscess, and is a great salute to the radiologist. He picked up dilatation of the gallbladder. It is very difficult to pick up. Even if we get it, we ignore, if we do not know what is happening exactly. So dilatation of the gallbladder was noted by the radiologist. That was a very beautiful clue to us. So what happens if we get, that means what is GB hydrops? It is nothing but non-inflammatory dilatation of the gallbladder. So there is no clear immunological basis why there is GB hydrop in KD. There are other causes, other diseases also. So KD is the most common cause, and incidence is 8 to 12%. And differential diagnoses are Epstein-Barr virus infection, leptospirosis, IgA vasculitis, systemic sclerosis, Sjogren syndrome, familial Mediterranean fever. These are the adult differential diagnoses. We can see the GB hydrop in this index file in the picture. So we have re-evaluated the child, and child developed on day 3 of admission, that means on day 13 of fever, typical periangual peeling. We have kept 2 pictures for skin peeling of the shoals to show the progression. Then in the hand we can see complete denudation, leaving this red, very smooth, shiny skin. So arthritis can develop in Kawasaki disease. It was discussed in the morning time also. It can be monoarticular, hip and knee joint arthritis. It can be polyarticular, which is very, very rare. And some people have described the arthritis as KD continuous, that means KD along with arthritis, that usually occurs in the later part of the first week, and reactive arthritis that occurs after 2 to 3 weeks after onset of fever. So we treated the child with 2 gram per kg IVIG and aspirin. Repeat debarbations was there. Joint pain subsided by 4 to 5 days. Repeat USG done, revealed normal GB size, and echocardiography revealed no coronary artery aneurysm. Follow-up after 2 months revealed some limping was still persisting. We instituted methotrexate in the patient. We need more evaluation of the case, maybe ERA which was associated, but we have started disease modifying agent in this child. Then this is a 8-year child, previously healthy male from Guwahati with fever, yellow discoloration was sclera. So basically that was referral diagnosis was acute on chronic liver disease. So we referred the case to gastroenterology department. So child had thrombocytosis, ESR was high, CRP was high, and TSB was high, AST, ALT raised more of AST, serum albumin was marginally low, and other investigations were normal. And ultrasound abdomen revealed prominent hepatic veins, and the radiologist has written to rule out cardiac cause. And there was also bilateral pleural effusion with ascites. When some confusion comes, then always seek a rheumatological opinion. That was the reason why we have involved with the case. That is the X-ray which shows enlarged cardiac cell rate. Echocardiography revealed massive pericardial effusion with impending tamponade. Pericardiocentesis was done and aspirated 250 ml of fluid, and fluid was blood stained with plenty of RBCs, and infections ruled out. So initially child came to pediatrics, then we referred to gastroenterology, then cardiology, then again come to pediatric rheumatology. So there was impending tamponade. We don't know what was the cause. Edema, ascites, passive venous congestion of the liver was there, which can explain all the features in the index child. There was no response to broad spectrum antibiotics, and blood culture was sterile. We re-evaluated the case. That is why that needs re-evaluation when we are in doubt. So there was persistent fever, anemia, thrombocytosis, markedly high ESR, CRP, serositis, and cardiac tamponade. So again, we missed the periangual plane, because these things were, we were busy with those things, and child already developed periangual peeling. So that was overlooked. So this was nothing but Kawasaki disease with impending cardiac tamponade, and several reports, even we have reported this series, our case series, in a very good journal. And we treated with pulse IVIG plus 3 pulses of methyl prednisolone followed by oral prednisolone. There was dramatic response, and child is on 5 years follow-up now and doing exceptionally well. And this was the Buse line, because very difficult to take a photo of Buse line unless it is stained with some unhygienic materials. So Buse line was there after 2 months on follow-up. We have noticed that. So that signifies retrospectively we are sure that that was Kawasaki disease. This is a 11-year-old girl with fever for last 12 days from Barpeta, where I am working now. So severe arthralgia of bilateral hip, elbow, and right knee joint. There was evidence of acute kidney injury. Platelet count was high, ESR, CRP were higher, and there was periangual peeling on day 9 of illness, and there was dramatic response to anti-IVIG. So interestingly, we have found one very interesting finding here: swollen heart pellet. It has not been, as far as I know, it has not been described in Kawasaki disease. This is described in allergies and infectious diseases. But here we have found swollen heart pellet in a child with Kawasaki disease. Other common presentations like not first manifestation, only cervical lymphadenopathy, nothing else, fever and cervical lymphadenopathy. That can be the only presentation of Kawasaki disease. Acute abdomen mimicking acute appendicitis. BCG site reactivation, we can see in the picture. I have found one case in our area previously when I was in training in PGI Chandigarh. I got another one case. So sometimes we can get. Then facial nerve palsy. Then retropharyngeal abscess-like presentation, that is also called retropharyngeal phlegmon. That is another presentation. Then nail changes in Kawasaki disease. Many literatures have described many changes in the nail, like orange-brown chromonychia. The president of Indian Kawasaki Disease Society, Dr. Priyankar Pal, have reported this. I think he is not here now. So orange-brown chromonychia, a novel finding Kawasaki disease. That onychomedesis in Kawasaki disease. I have one child recently, just 3 weeks back, picked up onychomedesis. That is the separation of the nail from the nail matrix. Then I have found one paper where all manifestations presented in one cell, single cell. Buse line, onychomedesis, chromonychia. So take home message is always suspect KD in any child with fever for more than 5 days, once or twice daily observation for new clinical signs and symptoms, 2 hours of atypical presentation, and diagnosis of KD is more an art than science. Probably we have seen it is more of art than science. I have not divided cases like complete or incomplete. This is to publish a paper. For diagnosis, no need. That is just a clinical observation. We can apply our common clinical applications. No need of any sophisticated investigations or whole exam sequencing. Okay. So now what is happening, because of I am trying to increase the awareness of on Kawasaki disease among the residents, undergraduate and postgraduate. So when I ask them fever with splenomegaly, what is the differential diagnosis? They start telling Kawasaki disease. So now the situation is like that. I am not, these are some deleterious effects. But still, we have put into their mind that Kawasaki disease can have many manifestations. That is very important. And thank you very much for your kind hearing.
Thank you, Dr. Sharma. You showed some of your cases have been diagnosed very late, 10 days, 12 days. I think that what is the cause of late diagnosis is because the concerned physician has not thought of KD. So early diagnosis is important for proper treatment, as you rightly told. So there is what mind does not know, the eyes do not see.
Exactly, sir.
So there is a need for sensitizing the general pediatricians everywhere, that in any case of fever more than 5 days, think of Kawasaki disease, because this is a disease which is not very uncommon. We are only missing it, so becomes uncommon.
Exactly, sir.
So this is the message that I want to convey, that early diagnosis is important. Sensitization of general pediatricians is also very important. So you must consider KD in the differential diagnosis of all cases, fever more than 5 days. Thank you. Yeah. Any question from the audience?
So when I have started my journey as a pediatric sorry, sir.
Is right. With capillary action.
So the cases are getting cured. That's the thing.
Exactly,
that is the
sir.
reality.
So when I have started my journey as a pediatric rheumatologist in Guwahati, first I worked in Guwahati Medical College, worked for 7 years after that, then transferred to various other medical colleges because I am a government job holder. So these things very common. So in Guwahati till now in northeastern state only one case was diagnosed with KD. Then subsequently we have started our clinic, and everybody knew that there is a clinic. So children from all northeastern states started referring cases to our clinic. So you believe or not believe, I don't know. In 2 years we have found 75 cases of KD. That has been published, and various manifestations including KD shock syndrome. Then now there are several years we have worked there in new places. In Jorhat I worked, we got several cases. Now in Barpeta, initially 0 cases. Now we have treated 10, 12 cases. So like that, awareness is the important. Thank you very much.